This section on acute coronary syndromes is one of the pillars of knowledge that you will need to know to successfully apply ECGs to your practice. And knowing how to diagnose and quickly treat ACS may actually help you save a patient's life. Cardiovascular disease is the #1 cause of death in the Western world, and most patients die as a result of coronary artery disease, either acutely with myocardial infarction or chronically as a result of heart failure or arrhythmias. For the purposes of your boards and shelf exams, I would recommend taking time to understand the ECG manifestations of acute coronary syndromes because this is an area that will be asked over and over again. The first thing that you need to know about acute coronary syndromes, or ACS, is that there is a spectrum of ischemia that can happen in the heart. On one end of the spectrum, you have stable angina, which is related to chronic supply-demand mismatch in patients. Patients with stable angina may report having chest discomfort and shortness of breath while performing routine tasks such as walking to the mailbox or up the stairs to their home. Angina can become unstable when symptoms occur or persist despite rest and taking vasorelaxing drugs such as nitroglycerin. Or perhaps the onset of angina starts to become unpredictable and unrelated with strict exertion. Some patients may even describe stuttering angina, which has paroxysms of chest pain followed by relief, but tend to get longer and more frequent the longer that this is unaddressed. Unstable angina may have serious consequences that require a hospital evaluation. Non-ST segment elevation myocardial infarction, or NSTEMI, is usually brought about by a significant blockage in the coronary artery leading to non-transmural ischemia within the heart. Patients often complain of chest pain with radiation to the arm or jaw, dizziness, shortness of breath, and the infarction is associated with a leakage of cardiac enzymes such as troponin I, troponin T, and CKMB into the blood. These patients are admitted to the CCU for immediate medical treatment and may receive a cardiac catheterization. Finally, on the other end of the spectrum is an acute ST segment elevation myocardial infarction, or STEMI, which signifies full transmural infarction of the heart, and which is a cardiac emergency requiring immediate revascularization, such as placing a stent within the coronary artery, as well as life-saving drugs such as aspirin, beta blockers, nitrates, and morphine. I did also want to mention that in addition to ST segments, much of the older literature describes the presence or absence of Q waves, which has prognostic significance. The presence of a Q wave is associated with increased infarction severity and reduced survival. Now, turning our attention to ECGs, it's important to start out with a potentially normal variant, early repolarization. Although early repolarization can be a rare, lethal genetic cause of arrhythmias, the vast majority of the time, early repolarization is a normal variant in young athletes, most commonly in males in their teens and 20s. You can see here that the ST segment is slightly elevated and stuck on to the QRS wave. Notice also how it has a concave upward curve that is in the shape of a smile. And notice how this typically occurs in leads V2 through V6. This ST elevation is caused from early repolarization and is not part of the ACS spectrum. Here's a close-up of leads V2 and V3. And these arrows show what we're talking about. You can see that although there is ST segment elevation, this occurs because there's an elevated J point and has a concave upward shape that is characteristic of early repolarization. This would not be classified as a STEMI. So with that in mind, now let's look at an ECG associated with unstable angina. Here we have a normal sinus rhythm with a normal axis. We see normal P waves preceding every QRS wave. And in leads V1 through V6, we have a progressively growing R wave. However, we do notice that the T waves are flat, or even slightly inverted or downward facing in leads that look laterally, like leads 1, AVL, V5, and V6. This flattening is syndromic of ventricular strain and ischemia that's happening in the LV free wall, which is on the left lateral portion of the heart, and denotes that the patient is losing some blood flow to this region. in this ECG, we don't see evidence of ST segment depressions or elevations, and if we were to check serum troponins, it is possible that they would not be significantly elevated, although in full disclosure, you could see troponin leak in this scenario. Thus, the diagnosis in this ECG is unstable angina. Sliding along the spectrum of ACS, we now come to non-ST elevation MI. Although technically NSTEMI can be diagnosed with a troponin leak and a lack of ST elevation on the ECG, there are usually some telltale signs that the patient is experiencing an MI with some wall infarction. For example, in this ECG, we see a sinus rhythm and a normal axis. We do not see ST segment elevation or Q waves, but when we look at inferior leads, like leads 2, 3, and AV foot, and also lateral leads V4 through V6, we see ST segment depression. This depression denotes non-transmural infarction within the infralateral wall. Most probably, this patient is having a leak of troponin enzymes associated with non-ST elevation MI. This patient should be admitted to the CCU for diagnosis, medical therapy, including heparin, aspirin, possibly beta blockers, and telemetry monitoring. And this patient actually may need a cardiac catheterization. And finally, here's an example of a huge myocardial infarction in the anterior wall. This is an anterior STEMI, and this is the big heart attack that you absolutely can't miss because a delay in therapy will cost the patient their heart and potentially their life. We can see this patient is in normal sinus rhythm and has a normal axis, and there's a P wave preceding every QRS wave. And when we look at the ST segments in the leads, which are highlighted in the anterior leads, we can see that the aneuroseptal and anterior leads, there's a massive elevation in the ST segment. In fact, the ST segment merges with and elevates the T wave as well. Typically, a 1 millimeter ST elevation in contiguous leads, for example, V3 and V4 or V4 and V5, is sufficient to diagnose a STEMI. But in this case, we actually see a greater than 12 millimeter ST segment elevation in leads V2 and V3, and in fact, the ST elevation is contiguous in leads V1 through V5. So this patient is having a major infarct in the anterior wall, which is primarily supplied by the left anterior descending coronary artery. This patient needs an emergency revascularization of the LAD artery and needs prompt referral to the cardiac catheterization lab for an angiogram and then stenting of this artery. This patient will be monitored on the CCU and will receive antiplatelet drugs as well as the usual ACS regimen drugs. One thing that you should know about the ECG is that its morphology evolves over the course of time. So first, before any injury, as expected, the ECG starts out with a normal QRS and a normal T wave. As ischemia first starts, ST segments can depress, and this can be associated with peaking of the T waves as seen here, and then possibly T wave inversion. Next, as the entire wall infarcts, you see ST segment elevation, and then the appearance of pathological Q waves. And finally, as the heart begins the healing process and fibrosis sets in, you can see normalization of ST and T waves, and then the persistence of a Q wave. A question I often get from students is, what is the difference between a normal Q wave and a pathological Q wave? Sometimes it's a bit difficult to tell, but I'll go over some basic features that can help you differentiate. So for a physiologic Q wave, usually you can see a small septal Q in the lateral leads, like leads 1, AVL, V5, and V6. You can see a little bit deeper Q wave depression sometimes in leads 3 and AVR. And under normal circumstances, a Q wave is usually not seen in leads V1 through V3. In a pathological Q wave, or a post-MI Q wave, you can get a Q with a width greater than or equal to one small box, which is equal to 40 milliseconds in duration. The amplitude of the Q wave can be greater than 25% of the height of the QRS. And usually you see Q wave changes that occur in two contiguous leads, like leads 2, 3 in foot, or V1 through V3. And so pathological Q waves are equivalent to transmural scar after an ST segment elevation myocardial infarction. Now I wanted to say a quick word on new left bundle branch block. Sometimes when a patient has an MI, left bundle branch block may occur from the infarction of tissue. The problem is that when there's left bundle branch block, this casts an electrocardiographic shadow over what's going on in the anterior leads of the heart, so it can be difficult to tell whether there is a pathological ST segment change, which could help you make the decision on whether to catheterize the patient or not. In this tough situation, if you have an old ECG which does not have a left bundle branch block, and now you have a new left bundle branch block, and also the patient has symptoms that are typical of a myocardial infarction, like chest pain or shortness of breath, this is enough to admit and catheterize the patient for presumptive MI. You would treat this patient as though they're having an MI while ruling them out. And depending on the interventionalist, they may in some situations proceed to a diagnostic or therapeutic catheterization. Also, I wanted to reiterate that we're talking about a patient with clinical ACS who has a new documented left bundle branch block, as we can see highlighted here. This does not apply to an old left bundle branch block or a left bundle branch block that is not happening in a patient with acute or active chest pain. So don't get confused. This is just a special case that we worry about in cardiology sometimes. This is less likely to be on the boards. Now that we've reviewed the waveforms in ACS, let's take a moment to apply our knowledge of vectors to localize MIs in the heart. So here's an anterior MI. Notice how there's ST segment elevation in contiguous leads V1 through V4. Given that the left anterior descending coronary artery supplies the anterior and septal walls of the heart, the patient is most likely to have a lesion in the LAD coronary artery. Now look at this ECG. When we view leads V1, V2, and V3, we notice that there is contiguous ST segment elevation in each of these leads, and the morphology of the ST segment is a downward concave tombstone appearance that is typical of STEMI. Also notice the lack of an R wave in V1 and V2 and the poor R wave progression into lead V3. These are typical of the ventricular septum and are syndromic of an aneroseptal MI. And here's the example of an inferior wall MI. You can see that in the inferior leads 2, 3, and AV foot, there are major ST elevations. Notice also how the ST segments have a more downward tombstone appearance. Almost looks like a frown. This is more characteristic of STEMI and not evidence of early repolarization. You can also see reciprocal T-wave inversions in lateral leads 1 and AVL. These are secondary changes to the STEMI going on in the inferior leads. Because STEMI is present, this is the diagnosis, and the reciprocal changes are rolled up into the diagnosis of a STEMI in this situation. Now here's a variant of the last ECG. This is an inferolateral MI. First, look at the lateral leads, 1, AVL, V5, and V6. You can see ST elevation in V5 and V6, and reciprocal changes in 1 and AVL. Next, look at the inferior leads, 2, 3, and AV foot. You can see large 4 mm elevations in each lead. This supports the diagnostic findings of a STEMI in the inferolateral leads, and given that the left circumflex coronary artery supplies this vascular distribution, we would expect that the circumflex, or potentially the right coronary artery, may have a lesion. Finally, here's a tricky one, a posterior wall MI. Notice how there's an inappropriately tall R wave in leads V1 through V3, and notice the horizontal T-wave depression that's associated with this. Also, notice the slight ST segment elevation in lead AVR, which points away from the usual vector of depolarization of the heart. All of these signs are syndromic of a posterior wall MI. Keep in mind that this ECG doesn't give us the benefit of having, super lateral placed leads wrapping around the back, and these are typically called leads V7, V8, and V9. Sometimes you can place these to take a look at what's going on at the lateral and posterior walls of the heart. If we had this, we might also see ST segment elevations in these unusual extra leads. These ECG changes, when coupled with troponin elevation and typical symptoms of MI, are virtually diagnostic of a posterior wall MI. So again, to reiterate, the ECG findings of a posterior MI are different than that of the ST segment changes found on other ECGs. An acute posterior MI occurs about 20% of the time, often with lateral or inferior MI as well. A true isolated posterior MI is more rare and happens in about 2% of cases. Sometimes in a myocardial infarction, you will see late, deep symmetric T-wave inversions. If you see T-wave inversions coupled with the typical symptoms of an MI, this is called Welland's sign and can be another classic sign of a myocardial infarction. Don't be fooled though. There are a lot of things that can look like this, and so the differential includes apical hypertrophic cardiomyopathy, myocarditis, pericarditis, and central nervous system disease causing long QT intervals, like in a subarachnoid hemorrhage. So you have to have these ECG signs coupled with the symptoms of a myocardial infarction to truly call this the Welland's sign. We all know that myocardial infarction is serious because it has a high mortality rate, and one of the reasons that the mortality rate is so high is because mechanical dysfunction resulting from an MI has electrical and arrhythmogenic consequences. 3 common complications of an MI are atrioventricular block, pulseless electrical activity or asystole, and ventricular tachycardia and fibrillation. Here's an example of AV block during a myocardial infarction. Notice how there's ST segment elevation in the contiguous leads V1 through V3 with reciprocal T-wave inversions. And then look at lead 2 on the bottom in the blue arrows. The blue arrows point to P waves that are not conducted to the ventricles. You can see that the QRS waves are independent from the P waves, and thus we have complete AV nodal block in the setting of a myocardial infarction. Also, this is just a reminder that VT and asystole can occur with MI. MI causes a scar and areas of slow conduction. And so this area of the ventricle can serve as a substrate for reentry, which is a fundamental mechanism of ventricular tachycardia.